Warfarin is a vitamin K antagonist used to treat venous thromboembolism, pulmonary embolism, thromboembolism with atrial fibrillation, thromboembolism with cardiac valve replacement, and thromboembolic events post-myocardial infarction. In this video, let's find found. What is warfarin? What is warfarin used for? Contraindication. What are the side effects of taking warfarin? How does warfarin work? How to use warfarin. What is warfarin? Warfarin is an anticoagulant used as a medication under several brand names including Coumadin. While the drug is described as a blood thinner, it does not reduce viscosity but rather inhibits coagulation. Warfarin first came into large-scale commercial use in 1948 as a rat poison. It was formally approved as a medication to treat blood clots in humans by the U.S. Food and Drug Administration in 1954. Warfarin is available as a generic medication and under many trade names. In 2020, it was the 58th most commonly prescribed medication in the United States with more than 11 million prescriptions. What is warfarin used for? 1. Prophylaxis and treatment of venous thromboembolism and related pulmonary embolism. 2. Prophylaxis and treatment of thromboembolism associated with atrial fibrillation. 3. Prophylaxis and treatment of thromboembolism associated with cardiac valve replacement. 4. Use as adjunct therapy to reduce mortality, recurrent myocardial infarction, and thromboembolic events post-myocardial infarction. Off-label uses include 1. Secondary prevention of stroke and transient ischemic attacks in patients with rheumatic mitral valve disease but without atrial fibrillation. Contraindication. All anticoagulants are generally contraindicated in situations in which the reduction in clotting that they cause might lead to serious and potentially life-threatening bleeds. This includes people with active bleeding conditions, such as gastrointestinal ulcers, or disease states with increased risk of bleeding, e.g., low platelets, severe liver disease, uncontrolled hypertension. For patients undergoing surgery, treatment with anticoagulants is generally suspended. Similarly, spinal and lumbar puncture, e.g., spinal injections, epidurals, etc., carry increased risk, so treatment is ended prior to these procedures. Warfarin should not be given to people with heparin-induced thrombocytopenia until platelet count has improved or normalized. Warfarin is usually best avoided in people with protein C or protein S deficiency, as these thrombophilic conditions increase the risk of skin necrosis, with rare but serious side effect associated with warfarin. Side effects. Severe bleeding, including heavier than usual menstrual bleeding. Red or brown urine. Black or bloody stool. Severe headache or stomach pain. Joint pain, discomfort or swelling, especially after an injury. Vomiting of blood or material that looks like coffee grounds. Coughing up blood. Pharmacodynamic. Warfarin is an anticoagulant, as such it disrupts the coagulation cascade to reduce frequency and extent of thrombus formation. In patients with deep vein thrombosis or atrial fibrillation, there is an increased risk of thrombus formation due to the reduced movement of blood. For patients with cardiac valve disease or valve replacements, this increased coagulability is due to tissue damage. Thrombi due to venous thrombosis can travel to the lungs and become pulmonary emboli, blocking circulation to a portion of lung tissue. Thrombi which form in the heart can travel to the brain and cause ischemic strokes. Prevention of these events is the primary goal of warfarin therapy. Limitation of thrombus formation is also a source of adverse effects. In patients with atherosclerotic plaques, rupture typically results in thrombus formation. When these patients are anticoagulated, plaque rupture can allow the cholesterol from the lipid core in the form of atheroemboli or cholesterol microemboli. These emboli are smaller than thrombi and block smaller vessels, usually less than 200 micrometers in diameter. The consequences of this are varied and depend on the location of the blockage. Effects include visual disturbances, kidney injury or worsening of chronic kidney disease, central nervous system ischemia, and purple or blue toe syndrome. Blue toe syndrome can be reversed if it has not progressed to tissue necrosis, but the other effects of microemboli are often permanent. Anticoagulation appears to mediate warfarin-related nephropathy, a seemingly spontaneous kidney injury or worsening of chronic kidney disease associated with warfarin therapy. Nephropathy in this case appears to be due to increased passage of red blood cells through the glomerulus and subsequent blockage of renal tubules with red blood cell casts. This is worsened or possibly triggered by pre-existing kidney damage. Increased risk of warfarin-related nephropathy occurs at INRs over 3.0, but risk does not increase as a function of INR beyond this point. Mechanism of action. Warfarin is a vitamin K antagonist which acts to inhibit the production of vitamin K by vitamin K epoxide reductase. The reduced form of vitamin K, vitamin KH2, is a cofactor used in the gamma carboxylation of coagulation factors 7, X, and thrombin. Carboxylation induces a conformational change allowing the factors to bind Ca2+ and to phospholipid surfaces. Uncarboxylated factors 7, 9, X, and thrombin are biologically inactive and therefore serve to interrupt the coagulation cascade. The anticoagulant proteins C and S also require gamma carboxylation to function. This is particularly true in the case of thrombin, which must be activated in order to form a thrombus. Vitamin KH2 is converted to vitamin K epoxide as part of the gamma carboxylation reaction, catalyzed gamma-glutamyl carboxylase. Vitamin K epoxide is then converted to vitamin K1 by vitamin K epoxide reductase, then back to vitamin KH2 by vitamin K reductase. Warfarin binds to vitamin K epoxide reductase, complex subunit 1, and irreversibly inhibits the enzyme, thereby the recycling of vitamin K by preventing the conversion of vitamin K epoxide to vitamin K1. This process creates a hypercoagulable state for a short time as proteins C and S degrade first with half-lives of 8 and 24 hours, with the exception of factor 7, which has a half-life of 6 hours. Factors 9, X, and finally thrombin degrade later with half-lives of 24, 36, and 50 hours, resulting in a dominant anticoagulation effect. In order to reverse this anticoagulation, vitamin K must be supplied either exogenously or by removal of the vitamin K epoxide reductase inhibition. Time allowed for new coagulation factors to be synthesized. It takes approximately 2 days for new coagulation factors to be synthesized in the liver. Vitamin K2, functionally identical to vitamin K1, is synthesized by gut bacteria, leading to interactions with antibiotics as elimination of bacteria can reduce vitamin K2. Half-life. R warfarin is cleared more slowly than S warfarin, at about half the rate. T1/2 for R warfarin is 37 to 89 hours. T1/2 for S warfarin is 21 to 43 hours. Dose. Venous thrombosis. Prophylaxis and treatment of venous thrombosis and its extension, pulmonary embolism, PE. Initial dose, 2 to 5 mg PO/4 qday for 2 days, or 10 mg PO for 2 days in healthy individuals. Initiate warfarin on day 1 or 2 of LMWH or unfractionated heparin therapy and overlap until desired INR, then discontinue heparin. Check INR after 2 days and adjust dose according to results. Typical maintenance dose ranges between 2 and 10 mg per day. Dosage based on genotype, see genomic considerations. DVT and PE treatment. Initiate warfarin on day 1 or 2 of parenteral anticoagulation therapy, e.g., LMWH or unfractionated heparin. Overlap warfarin and parenteral anticoagulant for at least 5 days until INR, greater than 2.0, maintained for 24 hours, then discontinue parenteral therapy. Stroke and thromboembolism. Prophylaxis and treatment of systemic embolic complications, e.g., stroke, associated with atrial fibrillation, AF. Initial dose, 2 mg PO/4 qday times 2 days, or 10 mg PO times 2 days in healthy individuals. Check INR after 2 days and adjust dose according to results. Typical maintenance dose ranges between 2 to 10 mg/day. Consider dosage based on genotype, see considerations. ACCP guidelines recommend dabigatran 150 mg PO bid over adjusted dose warfarin therapy for AF unless both AF and mitral stenosis are present. Cardiac valve replacement. Prophylaxis and treatment of thromboembolic complications associated with AF valve replacement. Initial dose, 2 to 5 mg PO/4 q-day times 2 days, or 10 mg PO times 2 days in healthy individuals. Check INR after 2 days and adjust dose according to results. Typical maintenance dose ranges between 2 and 10 mg. Post-myocardial infarction. Reduction in the risk of death, recurrent MI, and thromboembolic events, e.g., stroke, systemic embolization, after MI. Initial dose, 2 to 5 mg PO/4 q-day times 2 days, or 10 mg PO times days in healthy individuals. Check INR after 2 days and adjust dose according to results. Typical maintenance dose ranges between 2 and 10 mg per day. Rheumatic valve disease, off-label. Rheumatic valve disease, with any of the following: atrial diameter greater than 5 mm, left atrial thrombus, atrial fibrillation, and previous systemic embolism. Maintain INR 2.0 to 3.0 indefinitely. Cryptogenic stroke and patent foramen ovale with DVT, off-label. Maintain INR between 2.0 and 0.0 for 3 months. Cardioembolic stroke or TIA, off-label. Maintain INR between 2.0 and 3.0 indefinitely. ACCP guidelines recommend dabigatran 150 mg PO twice daily over dose-adjusted warfarin therapy. Systolic LV dysfunction, off-label. Systolic LV dysfunction without established CAD but with identified acute LV thrombus, e.g., Takotsubo cardiomyopathy. Maintain INR between 2.0 and 3.0 for at least 3 months. Antiphospholipid antibody syndrome, label. Antiphospholipid antibody syndrome with previous arterial or venous thromboembolism. Maintain INR between 2.0 and 3.0 indefinitely. Safety advice. Warfarin is listed as pregnancy category D, does cross the placenta, but is not found in breast milk. LMWH is listed as pregnancy category B, does not cross the placenta, and is not found in breast milk. That's all the information about warfarin we collected. Thanks for listening. Do not forget to like, share, and subscribe for the HeInfo channel if you like this video, to update more health information.